Afternoon, ladies and gentlemen, and a warm welcome from a magnificent Cape Town day. It's 35 degrees Celsius, not a cloud in the sky, and not a breath of wind. It's exactly the sort of day you should be at Clifton. Anyway, I'm glad so many of you, in fact, are not at Clifton, but are over here with us on this webinar. It gives me great pleasure, and it's a great privilege for me to present Professor Priya Soma-Pillay, who many of you would be familiar with. She at the moment is the acting dean of the University of Pretoria, and she's in fact also at the University of Pretoria Department of Obstetrics and Gynecology. She spoke many times and presented at the FIGO meeting recently in Cape Town and is widely traveled. And it's important for me to remember that she's also, apart from the sub-dean at the University of Pretoria, she's in fact the at FIGO, she's just been voted the assistant president of FIGO. So it's a wonderful, prestigious presenter we have, and she's presenting on damage to the cervix as a result of second stage emergency cesarean sections. And obviously, if you damage the cervix during the second stage, there's a risk of subsequent preterm labor and birth. So for these reasons, I'm enormously thankful for Priya to be with us this afternoon. And Priya, would you mind rolling your talk? Thank you very much indeed.
Good evening, Peter. Good evening, Stephen. Thank you for the invitation. This is pre-recorded, but I'm available for questions afterwards. So we can go. Thanks. Some of the work that we've been looking at the FIGO Preterm Birth Committee is the relationship between caesarean section and future preterm birth. And I'm going to present some of our data in the next few slides. I'd like to acknowledge my colleague, Professor Andrew Shannon, because much of the work that I'm presenting today comes from his research unit. Preterm birth is a major global health burden, and we are all quite aware of both the short and long-term consequences of preterm birth. Unfortunately, data from our Born Too Soon report shows that our rates have flatlined, and we haven't really made any strides in improving preterm birth rates globally. It has, however, always been believed that women who deliver at term are at reduced risk for preterm birth. However, recent studies have shown a significant association between full dilatation caesarean section and subsequent preterm birth. Caesarean section is a necessary life-saving procedure, but we are now seeing that it has important implications for future pregnancies. And what we are seeing is that in section, particularly at full dilatation, preterm birth in subsequent pregnancies. If we look at our caesarean section rates, we've seen about a 13% increase in global rates over the last 2 decades. In my own country, in South Africa, about 30% of women deliver by caesarean section. This rate is much higher in the private sector, where more than 80% deliver by caesarean section. Data from the United Kingdom show that about 5% of all Caesars are performed at emergency, but at full dilatation. And this rate has increased by about 44% over the last decade. Why is this so? We're not sure, but it's probably because of the increased litigious climate and change in training and practice. So in the next few slides, I'm going to show you why we think that caesarean delivery, particularly at full dilatation, is associated with an increased risk of future mid-trimester loss, but also preterm birth. What I'd like to show you is some of the anatomical landmarks that we use at caesarean section. So if we look at the first picture, most of us would perform a caesarean section electively with a Joel Cohen incision on the skin and a Monroe-Kerr incision on the uterus. And if we use those anatomical landmarks, we see that the occur at the lower segment of the uterus, which is perfectly fine. But what happens when a woman is in labor? The cervix pulls up, and if we use the same anatomical landmarks, that incision is then within the cervix, and this causes cervical damage. This study shows that this, in fact, is true. This paper was published in the ISWAP journal in 2027. Women were studied prospectively, and they had an ultrasound done 3 months after the cesarean section. Women were divided into 3 groups. Those who had the cesarean section performed at 2 centimeters or less of cervical dilatation. Those who had the Caesar between 3 and 7 centimeters cervical dilatation, and those who had the Caesar at more than 8 centimeters of full dilatation of the cervix. It was that of cases, if the cervix was less than 2 centimeters dilated, then the scar was found to be at the level or it was above the internal os in 97% of cases. However, if the Caesar was performed at full dilatation or more than 8 centimeters dilated, then in 42 out of 43 cases, the scar was found at the level of the internal os or within 5 millimeters of the internal os. And here we see the association between cervix at Caesar, the more likely that that scar is close to the level of the internal os. This is quite an eloquent study published a few years ago in the American Journal. Specimens of about 60 women who were premenopausal and exposed those uteri and cervix to a whole lot of tests. They studied the uterus and the cervix under microscopes. They exposed them to dye. They exposed the uterus and cervix to drugs like oxytocin and nifedipine and looked at whether they would contract and which muscle would contract and which wouldn't. And if we look at the first slide here, we see that the staining of the internal os and the external os is quite different. And we see a more red staining of the internal os than the external os, suggesting that the tissue of the internal os is quite different to that of the external os. It was always taught in medical school that the muscles of the uterus consist of smooth muscle fibers, whereas the cervix consists mainly of collagen. But what the authors found in this paper was that the internal os of the cervix is very much like the uterus and consists of 70% of smooth muscle fibers. And these muscle fibers are actually circumferentially arranged in a circular fashion, forming a sphincter at the internal os, whereas collagen is found more in the lower parts of the cervix and the external os of the cervix. So it is now believed that if there is a cut or if the cesarean incision is made at the level of the internal os, we are now damaging that internal sphincter, causing damage to the integrity of the cervix. This study was performed by Andrew Shannon and his colleagues, and this was a retrospective cohort study where they looked at 2 groups of women. In the study group consisted of women who had a cesarean stage, some of them in the second stage. The cesarean section was followed by a preterm birth, and then we have the index pregnancy that was studied. The control groups consisted of women who had a previous preterm birth, and then the outcome in the index pregnancy was studied. So both groups had women with a previous preterm birth, but the study group had women who had an emergency cesarean section as well. And if we look at the data on the table here, we see that delivery before 37 weeks in the emergency cesarean group, 54% of women delivered before 37 weeks compared to only 20% in the control group. Of those 54%, 62% of women had a second stage emergency Caesar. Some 34 weeks, more women in the emergency Caesar group delivered preterm than those in the control group, suggesting that emergency Caesar, and particularly the second stage Caesar, has got something to do with subsequent preterm delivery. This study was performed in Sweden. It was a retrospective study looking at more than 11,000 women who had an emergency cesarean section at term and had a subsequent preterm delivery. What they found was that the lower the station at the time that the cesarean section was performed, the greater risk of a subsequent preterm birth. So this just confirms the findings of Prof. Andrew Shannon's work that I presented in the previous slide. This paper was published in the American Journal by Amrita Banerjee and her colleagues, and she asks if the internal os is damaged, how can we predict which women are going to deliver preterm? And they examined the cesarean scar post-delivery of women who delivered by emergency Caesar. They also looked at the cervical length of these women. And what they found that if the Caesar scar was at the level of the internal os or within 5 was less than 25 millimeters, then these women are at risk of delivering preterm, and these women should be monitored during their pregnancy. What is the role of cerclage in these women with previous emergency Caesar at full dilatation? Again, this is the work of my colleague Andrew Shannon in London, and he looked at two groups of women. The study population had 209 women. They had an emergency Caesar during labor. They had a following pregnancy that was a preterm birth, and these women then had a cervical or vaginal cerclage in their index pregnancy. This group of women was compared to the control group, who had a risk factor for preterm birth and had a vaginal cerclage in the index pregnancy. And what they found was that, so both group of women had a previous preterm birth, but the one group had an additional emergency Caesar at term. What they found that is that women with this vaginal cerclage with a previous emergency Caesar, that 30% of women delivered before 30 weeks gestation, compared to only 3% of women who did not have the emergency Caesar. If we look at delivery before 37 weeks, again, it's 59, suggesting that a vaginal cerclage doesn't seem to work in these women who had a previous emergency Caesar. So if the integrity of the internal os is damaged, it suggests that the vaginal cerclage doesn't work for these women. What about the role of transabdominal cerclage? And this paper was published in the American Journal in 20 pregnancies were studied. All of these women qualified for a cerclage. And all of these women had an emergency Caesar at full dilatation, followed by a preterm birth. They then had either an abdominal or a vaginal cerclage in the index pregnancy. And what they found was that in the abdominal cerclage group, 19 out of 90, compared to only 17 out of 31 in the vaginal cerclage group. If we look at delivery less than 30 weeks, 48% of women delivered preterm in the vaginal cerclage group, compared to 16% in the abdominal cerclage group. Delivery before 24 weeks, 35% in the vaginal cerclage group, and none in the abdominal cerclage group, suggesting that abdominal cerclage works probably better in these women who've had their Caesar at full dilatation. So this is just something that we are discovering. It's a small proportion of women who subsequently deliver preterm, but I think we need to be aware of it. So I'd like to conclude by saying that there seems to be an association between full dilatation cesarean section and future future preterm birth. This does pose a growing clinical problem. We need to address this problem. We need to see how we can reduce our rate of second stage cesarean section. And we need to probably look at improved management of second stage labor and the role of assisted deliveries. We probably also need to look at future research, looking at the underlying mechanism of the damage of the internal cervical os. But what I wanted to highlight is that cervical cesarean damage and its implications for future pregnancies must be recognized and considered in labor management plans. Thank you very much.
Thank you very much indeed, Priya. Chris, is Priya with us, or she's still online? Oh, there you are.
Yeah,
Priya,
I'm here.
Just tell me, thank you. It's a wonderful, wonderful presentation. Has the storm hit you, or is the storm passed over, or how far is the storm in Pretoria?
Storm is about to hit me. Yes, but I noticed, I'm not sure whether it was on your side as well, that some of the recording was cut or the voiceover wasn't very good. I'm not sure whether it's my network, so apologies for that.
I
Cut
thought
a
that
little bit
was
on my
due to the
side, but
storm.
yeah, cut a bit on my side, but it was okay. We could. It wasn't much, so it was fine. Was yours okay, Pete?
Yeah, no, I did. I did have some interruption, as Priya mentioned, but I thought that was the storm. So I put that interruption down to the storm. But we certainly got the gist of Priya's talk. Steve, do you have any questions? I've got a few questions on my side. Would you just kick off with your questions, if you don't mind?
Well, I mean, thanks, Priya. I think you guys are. I mean, for the it's so nice to see people making such wonderful progress in trying to really understand what's happening in preterm labor and looking at different etiologies. I mean, it's great. It's a pity that Andy didn't really show much in terms of that circlage, but I think we can talk a little bit about second stage C-section now, Pete. But I think you're far away with maybe your questions a little bit more relevant to the.
Okay, yeah, I'm going to fire away with cesarean section. The first thing is this. Those people like myself that do lots of cesarean sections, our work in private, it's very, very important in the second stage of labor to have one or 2 points in mind. If the presenting part is very low in the second stage of labor and a cesarean section is indicated, let's say for argument's sake for fetal distress. Firstly, disimpaction of the fetal head is a dangerous job to do. There are various ways of doing it. And I have seen terrible outcomes when people, usually, unfortunately, it's the least experienced midwife that is roped in to put her hand in the vagina, her gloved hand, and push Kefalad to disimpact the head. The problem there is that you can damage the fetal skull and even fracture the fetal skull to such an extent that fetal damage can occur. So if you are going to, in the second stage of labor, disimpact the fetal head, which is usually a very good idea to do, ensure that your best midwife is doing it and ensure that your best midwife is extremely gentle. Now, I am aware that there are ways and means of disimpacting the head with balloons and other ways to try to do this gently. But the idea then is during disimpaction of the head, she will push the fetal head, or fetal presenting part, Kefalad. And when you do your incision, be sure you do not do what I call a supracervical incision or even an intracervical incision. Make the incision under these circumstances particularly high because the uterine lower segment is very, very thin, extremely attenuated. And if you make it as Priya pointed out in her initial slides, if you make it in the usual spot, you're going to be far too low. Go much higher than usual. And when you've gone higher than usual, another 2 centimeters up, Kefalad, because otherwise you're going to be doing a supracervical cesarean section, which is, number one, extremely difficult to close, and number two, will damage, as Priya has suggested, the internal cervical os. So that is the very first point to do. The second point to do is when you do lower segment cesarean sections late in the second stage, be particularly careful about other factors like damaging the bladder, causing hemorrhage, and inappropriate techniques. So please, ladies and gentlemen, when you do your cesarean sections in the second stage, disimpact the head by the best midwife possible. Be very gentle, don't damage the baby, and go particularly high. Select a spot and then go 2 centimeters careful at. Thank you, Steve. That's my opening remarks. There more to come later.
Yeah, I'd like to just ask both of you, because I mean I'm not really much of an obstetrician, but you know, do you think there's enough recourse to instrumental delivery these days, or are some of our trainees running away from you know, forceps and vacuums and to Caesars a little bit more commonly? Because I mean, obviously, if there's a low you know, impaction at full dilatation, do you think we're finding that trainees are getting enough experience in instrumental deliveries, or do you think well, I'm just a question really.
Priya?
No, if the indications are correct and if the prerequisites are met, we still encourage our registrars to perform and practice assisted delivery. So it's not something that is being reduced. And for the CMSA logbook, they still need the prerequisite a number of assisted deliveries.
And which instruments do you use and teach your registrars, Priya?
Use both, but the vacuum, either the Kiwi or that seems to be more favored than the forceps.
Yeah.
Okay.
I must say, Pete, when I just on this point, you know, when I did my reg time, yeah, but I went and worked as a registrar in London, and I certainly found that you know, in the UK they were much more au fait with the forceps than we had actually been at UCT. And maybe it was just the time of you know, training, etc. But you know, I did find that you know, and I think maybe recourse to forceps, which is often a little bit more successful in that very low impacted head, might be something that some of our registrars might still need a little bit more experience with. You know, vacuum is easier to do and easier to learn, I think, but a good forceps is often something that registrars still need to learn. So, you know, that's maybe just something that we should think about as well, to try and avoid these very difficult seizures, which I indeed was you know, exposed to quite at one point. And I did actually in London get called by a junior registrar once to come and help with the delivery of head, and in the end we did actually cause a skull fracture trying to get this baby's head out. So, you know, this is obstetrics at its very most complex and difficult. So I'm very glad you've at least you know, brought this very difficult discussion up, Priya, and you know, just seeing how this all fits into other complexity of preterm labor is also interesting. What other questions did you have, Pete?
Steve, yeah, there's a question over here. In our heightened circumstances of litigation, particularly in private practice, where the obstetrician is a particular risk, is it, this has just come through over now, is forceps a preferred option over vacuum, given that any damaged baby of any description will almost certainly attract some form of litigious process? In other words, I think what they're saying is, under these circumstances, would it be prudent to do a forceps, which may, under difficult circumstances of delivery, lead to litigation? Priya, how do you respond to that question?
I think as long as guidelines have been followed and what has been done is well documented, if the prerequisites are met, if preferably the assisted delivery should be done in Caesars, I mean in a theater, so that if the procedure fails, one can convert to a cesarean section immediately. I don't like separating, you know, private practice from public sector, because the climate is the same everywhere. But I really do think there's a role for assisted delivery, and we shouldn't abandon that practice and also the training of assisted deliveries. And I think if a successful assisted delivery is probably safer and associated with less morbidity than a second stage cesarean section.
Absolutely.
Thank you.
I agree.
Sorry,
Can I just
Steve?
say something, Peter? I absolutely agree with you. I did actually do a lot of instrumentals myself. And, you know, I think the absolute, you know, just following the rules, picking the right instrument from the beginning, you know, I think the minute you've got that vacuum on and then you go to the forceps, that brings alarm bells up for any lawyer or any expert looking at a case. Document that you've, got all the, ticked all the right boxes for your instrumental delivery, and go for it. And as you say, I mean, we find that doing that in theatre makes it a lot safer. Everyone is there, and you're much more likely to abandon a difficult forceps in theatre than in the room when you've actually committed to it. Whereas in theatre, everyone is there, and if you indeed get the baby out with the forceps, everyone is happy, and if you go to Caesar, everyone is ready. So I don't know how often this is done in private, but I think theatre-based instrumental is really, I think, quite a safe procedure.
Okay. There's another question come over here. Given to what Professor Priya has just said, the greatest litigation burden is on the private practitioner who stands alone and is not indemnified by the state. And secondly, the highest incidence of assisted delivery, the highest incidence of CP, cerebral palsy, I guess, is a result of assisted delivery and not at cesarean section. So I think what they're saying is the burden here of litigation falls upon private practice and not the government person who's indemnified by the state. And secondly, there seems to be a lower chance of fetal damage and CP if it's done by Caesar rather than assisted delivery. How do you respond to that, Priya?
My response is similar. If the prerequisites are met, and if protocol is followed, timelines are followed, then again, I would prefer an assisted delivery, and I don't want to distinguish between private and public. We should have one protocol for labor practice, and if it's all well documented, then that is defensible. If protocol is followed and all of the timelines and notes are well documented, you should be able to have a good defense.
Okay. Another question is, how do you train your registrars in late second stage delivery to assure a safe outcome? In other words, what do you guys do to prevent this supracervical cesarean section incision? Is it, as I mentioned in the beginning, or do you have better mechanisms?
What you're saying, try and identify the anatomical landmarks and cut higher than you would have, and even 2 centimeters higher than you think you should be. And that's what, I always hear Ari Mouton saying that to the registrars. Second stage Caesar, if you think you should cut higher, cut even 2 centimeters even higher. Exactly what you said earlier.
Yeah. How do you disimpact the fetal head in late second stage? What is your recommended option, Priya?
We don't have the fancy fetal pillows that are currently being described in the text, and unfortunately, often what happens is we ask an assistant or a midwife to assist with this impacting the head from vaginally. Yeah.
Yeah, we don't have those either, because I'm not sure if they've been validated. It's a very difficult thing to validate, given that this isn't that common. Secondly, and I'm not sure how they work or if they've been tried. But it's very difficult to prevent fetal damage, and that's why I'd say that the gentlest midwife with the best approach would be better. Have you heard of Tim Draycott always shows that very scary picture of a baby that was disimpacted in the second stage, and you just see the midwife's fingers that caused the skull fractures and the baby demise. It's a hell of a story.
I've heard of that.
I've seen that picture.
Can I just ask you guys, when I used to make the call for a second stage Caesar, often just doing a little bit of disimpaction yourself before, is that something that you'd recommend?
Yeah.
I mean, once you've actually said, okay, this baby's going to go through Caesar, then I would often just try and do something, maybe even give it a little bit of a tocolytic quickly and disimpact it yourself before.
Yes.
I don't think that's practice.
Yeah,
But what
I agree.
tocolytic would you use, Steve? There's a good question. What tocolytic would you use?
You're gonna have to ask Priya that. I mean, let's hear from the experts.
Usually with our emergency cesarean sections, we give a bit of tocolytic anyway as part of the intrapartum resuscitation. So a bit of the salbutamol is also fine.
Yeah. We don't have salbutamol intravenously available. The only one that we have that really works, obviously, is the one that you possibly would not have. That's Tractocel. But I spoke to Phil Steer. I said, can you use it? And he said it's never been described under these circumstances. So, in other words, he doesn't think it's a good idea. Steve, there's some more questions. I don't want to dominate the questions. Would you just bring up a few more?
Absolutely. Yeah. So Gerrit John has asked about the new WHO guideline regarding the management of labor and will result in longer labor and more emergency C-section late in labor.
Sorry, WHO.
There's a new WHO guideline on the management of labor, and he's commenting that it will result in longer labor and more emergency C-sections late in labor. Is there any comment? Are you either of you familiar with the new WHO guideline?
I didn't know there were new
and it allows for longer labor, but I don't necessarily think it's going to result in longer second stage deliveries. We should still keep to our time for second stage. And, there should be that acceleration after 7 centimeters, and we shouldn't really have too many deep impacted heads if labor is managed appropriately. I will have to wait and see, look at the data following the implementation of these guidelines. But I'm hoping that it's not going to result in that.
Does it give a little bit more liberal time for the second stage in that guideline or not?
As far as I know, the second stage is still the same. It's the latent phase is longer now, so active management is starting at 5 centimeters.
Okay.
But the second stage shouldn't change.
Okay, thank you. Pete Russ has got a comment here, and he's saying, regrettably, some years ago, an anorectal surgeon stated at an ONG conference that a forceps delivery under any circumstances was medico-legally indefensible. Any comment from either of you on that? Well, I mean, I think we've already said enough about forceps and its role. I don't think we can already be dictated to by our colleagues who don't practice obstetrics. And we know that a forceps is life-saving in a lot of babies' lives. So, and as someone who does practice pelvic floor surgery, I still feel that the forceps is a very good option in obstetrics. Any further comment on that, Pete?
Yeah, no, it's a very difficult thing. Can I just quickly get to Steve, just before I comment? We've got a lot of questions coming through, and I'm scared that we're not going to have time. Anonymous says, this is for Priya, can a DeLee incision be of help in these cases? Can you just tell us what is a DeLee incision, and can it be helped in these cases, Priya?
DeLee incision is the vertical incision in the lower segment.
Yeah.
As long as that incision doesn't stretch down, go down into the cervix. So I'm still in favor of a transverse incision on the lower segment, but one should ensure that it's not low, not supracervical, that it's actually in the lower segment and not in the cervix.
Yeah, thank you very much. So that's do a Munro curve, which is the lower segment, do a transverse, but much higher than you would think. And instead of putting it where you think, put it another 2 centimeters higher. Raul Antonio Fuentes, is there a role for tocolysis? We've mentioned that. It would be wonderful if you can give tocolysis if you have effective tocolysis. Randy Chikosi says, I was a reg. I don't know when Rendani was a reg, but Rendani says, when I was a reg and I finished my registrar time without seeing an abdominal cerclage.
Cerclage, Pete. Yep.
Huh?
That'll be cerclage that he's talking about there.
Yeah, I think so. How are we improving the skills for abdominal cerclage, I reckon, whether open or laparoscopic in registrar's training? Priya, could you comment on that, please?
So abdominal cerclage is still not regarded as, it's seen more, and in our institution is done more by the subspecialist, either the gyne-oncologist or the reproductive specialist. And it's not part of the general gyne clinical training.
Yeah.
So I think it's not something a procedure that we ensure that registrars get trained with, but there are colleagues in our country who are able to perform it, and that's something that a patient can be referred for and done at an elective stage.
So that is very much the province of a maternal fetal specialist. You mentioned this last week, where we've got a colleague who is a laparoscopic surgeon that does them in 45 minutes. He's extremely adroit. So that is certainly the province of the specialist then. There's another question here. Gerard Turan says, remember that horizontal traction on the anterior shoulder of the fetus with the other hand prior to insertion of the delivery hand. So in other words, you disimpact the baby by horizontal traction on the anterior shoulder of the other hand prior to insertion of the delivery hand. Priya, would you like to comment on that?
No, that's fine. I support it.
Okay, you say yes?
Yes.
Steve, we're running out of time here. What is the time actually?
Only 25 to 6, Pete, actually, so there's no real rush, actually.
Okay.
Yeah.
So we're not really running out of time. No. Anonymous attendee says, concerns about maternal morbidity. That's interesting. Maternal morbidity, that's an important thing we haven't spoken about. Maternal morbidity, short and long term, of second stage Caesar versus assisted delivery. Any comments? Do you get these questions? Are they on your screen, Priya, or not?
I'm getting some of them, but not all of them.
Okay. So what would you say? Maternal morbidity of a second stage Caesar versus an assisted delivery. Any comment?
So the data at the moment, I would say a Caesarean section is associated with a much greater risk of morbidity than a successful second assisted delivery. If one considers the anesthetic risk, the risk of a scar for future pregnancies, the increased risk of stillbirth, the maternal, damage to, in both cases, there's a risk of damaging maternal organs. But the data currently would suggest that a Caesarean section is associated with greater morbidity than a successful assisted delivery.
Okay. Can I ask Steve for his comment as a pelvic floor master? Does the pelvic floor get damaged more from an assisted delivery than a Caesarean section, late second stage delivery, Steve, as a pelvic floor specialist?
Well, thanks for bringing that up, Pete. Because I think when we talk about morbidity, we're all thinking about that disastrous, tear, women bleeding. I remember at Caesarean, we once packed a patient's vaginal with about 30 abdominal packs. It can be quite, distressing to manage some of these severe traumas. But absolutely, I think if you look at the data on forceps and vacuum, that is what really causes a lot of the pelvic floor damage that ultimately leads to prolapse and incontinence surgery later in life. So, there's no question about it. All the research will point to that being absolutely one of the most important causes of, patients requiring some pelvic floor surgery later in life. But you've got to weigh that up against, all the other advantages of vaginal deliveries and the disadvantages of C-section. It is the C-sections that do ultimately often lead to a maternal death. Weighing that up against a prolapse surgery or incontinence surgery later in life. So, we don't really, I personally never really feel that, it's a strong enough indication to go and do a C-section. But, I think everyone needs to weigh that up. And there are multiple risk factors. It's a multifactorial issue. We're talking about collagen deficiencies, and many other things, chronic constipation, other increases in abdominal pressure that will ultimately lead to someone having pelvic floor dysfunction too. So it's a very difficult one. I know some guys in Scandinavia have tried to put a little bit more data and statistics together for this to help us counsel our patients, but it remains difficult to do a C-section only to prevent pelvic floor damage.
I don't think we're there yet.
Yeah.
Somebody said, with regard to, apropos Peter Rosa's question about, it says, Peter Rosa's question said, regrettably, some years ago, an anorectal surgeon stated at an ONG conference that forceps delivery under any circumstance was legally indefensible. You remember that question? Another guy's come through and said, he wonders if Pete Roos doesn't mean the SASOG Congress at Drakensberg, where there was a talk by a lawyer that said that. I think that a lawyer would have said. That's the sort of thing that a lawyer would have said. And then over here, we've done that one. We've done
the
that
last one, yeah, Pete, by Irung
Smoosh,
Daniel
I
Amboy.
see.
Irung, yeah? Do you
Yeah.
know him? Her. Irung Daniel, it's a him. In case of an impacted fetal head during the second stage emergency, would you, Priya, advise a reverse breech to disimpaction of the fetal head? In other words, would you do a reverse breech to disimpact the baby?
Yeah. So that is one of the techniques described, and it can be is sometimes associated with less morbidity. I've done a reverse breech a few times,
What's
and
a
it's
reverse
something that
breech?
can where
What is?
the
Could you tell us what a reverse breech is?
yeah, sure. So it's where a reverse breech is a technique where the impact head is where the baby's bum and the legs are delivered. So the breech is delivered before the fetal head. So instead of where the baby's legs are pulled up and it's pulled through the uterine incision as a breech delivery, rather than pushing the head out through the incision first. Do you understand what I'm saying?
Is that what Gerard Ron said?
It's considered a pull method rather than a push method.
How
Because
practical is that when the head is stuck there? How practical is it to pull the baby out from the top, breech first, then to disimpact the head? Which do you think is
done? So you put your hand in the uterus and you grasp on the feet first rather than putting your hand to push the head up first. And it is described and it can be done.
Okay.
I once, Pete, when I was a registrar, one a very enthusiastic midwife pushed the head up so fast that the baby turned into a breech, and I ended up delivering as a breech anyway. So, so I did do I don't know if you'd call that a reverse breech, but I'd maybe call that an unanticipated breech.
Yeah.
Someone has given us quite a long question. It's the anonymous attendee, and it says,
can you just give us
I'm not going to read the whole one. What are your views on teaching doctors to distinguish the upper limit of the lower segment from the upper segment? And which landmarks do you use to teach? And I suppose it's the same sort of the 2 centimeter rule. Does that remain just the basic approach to this, or is there any other trick we can do in doing this? Anything else you want to add to the whole positioning?
This anonymous, yeah, it's a very good answer. I've seen this as a model answer in some of the exam questions looking at managing the second stage. So this is actually a very good write-up by this anonymous attendee and the different methods of delivering the fetal head. So disimpacting by the surgeon, non-dominant hand disimpaction, reverse breech, which we discussed now. Yeah.
I do like the idea. Yeah. I do like the idea of using your left hand. I think that is something. And then also found that just, we haven't spoken a lot about the impact of, someone with a large size hand like mine, you start leveraging that breech out through a small lower segment incision, you start creating massive tears in that lower uterine segment. So I would always say to my registrars, be careful how you lever your big hand. I mean, use your fingers when you're doing that, and don't sort of use your whole fist to get that baby's head levered out either. I think that's actually quite an important point too. But yeah.
Okay, can I just finish that question? I don't know what's a pathoarthron maneuver. Do you know that or not, Priya? That question. You don't know that. Okay, well, let's leave that alone.
And look, you can ask ChatGPT later, Pete.
Okay, I'll do that. Then it says there, kiwi extraction can be used intraoperatively for a deeply impacted fetal head. Remember that I spoke to the kiwi manufacturer and they go against that. They say there's absolutely no evidence to say that the kiwi should be used or may be used or is licensed for use at cesarean delivery. I guess that's for preventing any medical legal damage. However, a soft cup has been used. There's been a few papers on that. There was a paper at the British Congress in London 4 months ago, and there was an abstract at the latest FIGO on the use of CSAIDs for delivery of the fetal head at cesarean section. However, and this is the important thing, that when a soft cup is used, that's the one that has been described during cesarean delivery, a certain governed vacuum is used, so there's not going to be damage to the fetal head, there's not going to be any laceration of the fetal head, because a governed vacuum is used. Minus 60 is used to prevent any chignon or aponeurosis damage. That has been used comparative to forceps, and so I would go against the use of a rigid cup for delivery of the fetal head at cesarean section. Rather use something that has been proven, and you would need to have a governed vacuum that can be applied, an instant vacuum applied at a certain, as I say, 60, minus 60 kilopascals. And minus 60 kilopascals is safe. It's never been associated with any cephalhematomas or aponeurotic damage. Your comment on that, Priya?
No,
Vacuum at cesarean delivery.
Yeah, I've never done that, and it's not something that we teach at our department, a vacuum.
Do you have access to soft cups and vacuum deliveries and electric vacuum pump deliveries?
Do have access to soft cups, but we don't really do vacuums or we don't do vacuums at cesarean deliveries. We'd rather do, use methods to push the head up, do the reverse breech, which is very similar to the Pathwaden method that you spoke about earlier on, which is similar to a reverse breech, where the head and the armpits where the armpits and the legs are delivered first.
Okay.
And a wedge is inserted to lift the fetal head. Yeah. But I'm not experienced at all with a vacuum at cesarean delivery.
Yeah, but there is.
I can't comment on that.
Well, I can comment because I'm familiar with the actual academic literature of the use of vacuums at cesarean delivery. Not, I might add, for the use of impacted heads. That's something completely different, and that is where we're talking now. So the use of vacuum is a little bit left of center, off piste. We have spoken about that on this platform previously, but for now, it's obviously not part of it. Are there any other points that this anonymous person mentioned that we haven't? Yeah, it's one of the points over here. It says, when teaching juniors to cut higher, this language could lead to cutting too high as well. I've never ever seen this happen in an impacted head, that you cut too high. I've often seen it that you cut too low, but I've never yet seen when a person cuts too high. Would you say that happens, Priya?
No, but I think it's also good to palpate the uterus before making your incision. And I agree with you. I've never seen someone cut too high.
Yeah. There's Tabo says, is the classical uterine incision superior? That's the classical midline uterine incision, superior to a high transverse uterine incision. How would you approach it?
I'm not aware of any data comparing it, so I can't comment on data. But in terms of experience, one is still able to do a high transverse incision successfully.
Okay, so the answer is no. Do you have any more questions, Steve?
Absolutely. So I think it would be good just to circle a little bit back to the initial topic for the evening.
Yeah, we've gone a bit off piece.
And
sometimes
I do like the concept that Priya's brought up, and really just bringing to mind the impact of these very late C-sections actually on preterm labor. And I was just wondering how close we are to, in the case where we are quite desperate to get a woman to term who we strongly believe has a second stage C-section as a cause. Are we at the point of where it might be acceptable to do a cerclage, Priya, or how's your practice? How's this affected your practice?
This is quite new data, and we haven't really seen too much of or we haven't been aware of some of the clinical implications. But the data suggests that a vaginal cerclage is probably not going to work. Similarly, we don't know the effect of, because we just don't have the data, the effect of progesterone in these women with a previous second stage cesarean delivery. The study I presented with the abdominal cerclage, the numbers were very small, but it does seem to suggest that an abdominal cerclage is superior to a vaginal cerclage in this cases. But what we have seen in the one paper published in the American Journal is that, and what I must say is that not every woman who's had a second stage cesarean delivery is going to deliver preterm, and not every woman is going to require a cerclage. At the moment, the proportion of these women who deliver preterm is still quite small. It's less than 2%. But we need to be aware of these cases. And the suggestion is that in women who have a second stage Caesar, one should look at where the cesarean scar is. If you want, this can be done 6 weeks after the delivery. And also look at the relation of the scar to the internal os. So we should be aware then of the Caesar scar post-delivery, and then just have extra vigilance in the subsequent pregnancy. And women won't qualify for a cerclage in the immediate pregnancy following the second stage. I think we need to just look at that pregnancy. If she does deliver preterm, then that's probably an indication for a cesarean section.
Thanks, Priya. I mean,
the data is very early, and we shouldn't be putting cerclages in everyone following a second stage Caesar, because we don't know whether the risk-benefit ratio as well.
Thanks, Priya. And I would encourage those of you who weren't on last week's webinar, I mean, because this really dovetails beautifully with a talk we had last week from Lopez Turius on preterm labor. So, and this does really help a lot to, feed into what Lo was telling us last week. So that talk is available online already, Chris, I assume. And those who want to go and look at it who weren't here last week, I think it's very nice to go and see just some of the risk factors, etc., and how to manage those preterm labor patients as well.
Just for Priya, I don't know if she was with us. What Lo was saying is that at the 13-week or 14 or 12-week fetal assessment, you measure the cervical length. And I guess that, as Steve says, if a woman's had a previous cesarean section late in the second stage and she's got access to some form of assessment in the at the end of the first trimester, beginning of the second, that would be exactly the first thing to look at, is the cervical length, because if it's shortening or beaking, then that would indicate that a vaginal cerclage is indicated. And on that link,
and one can still do an abdominal cerclage, early in pregnancy.
I must say I've never tried that. Theoretically, as you say, on the basis of what you show, that would be a better thing. My good colleague, Dr. Halen down here, in Cape Town down here, he does abdominal cerclages. He does them both laparoscopically and abdominally. I don't know if he does them vaginally, doubt it. Which would you say is the preferred method, laparoscopically or abdominally, Priya? Or is there no data to suggest a difference at this stage?
I think it also depends on the surgeon and the competence of the surgeon. If the surgeon is, competent laparoscopically, that's the way to go at the moment.
Okay. Sorry, Steve, did you want to say something? I saw you.
No, not at all. I think no, I don't have any comment on at this stage.
We've just had another question over here, but you've just answered it. It said, which is the preferred option for abdominal cerclage, laparoscopic or laparotomy? The answer is whichever you are adroit at. The best way that you can do it is the best way to go. Would you agree with that?
I agree.
Yeah. Steve, I think we're just about running out of time over here.
Absolutely. Would you like me to say thanks? I mean, it's been such a wonderful talk, and thanks for bringing up such a new and novel way that we should be looking at preterm labor, Priya. And I think you've prompted a vast amount of discussion about a very important topic that affects the lives of every obstetrician. So we do appreciate you bringing this topic up, and I think we've really touched on a lot of very important topics. Thanks for taking your time to to spend with us this evening. We know you're very busy, So we do appreciate that.
As Vice Chairman of
Yeah.
FIGO.
Yeah,
Yeah,
absolutely.
you know, this, Steve, I was at the FIGO and I went to all those, I don't know if Priya was there, went to all those talks on cesarean section, and it's an enormously nuanced subject. And there's a lot of people with completely different points of view. And I think that our approach to cesarean section must be much, much more elegant than it is now, and much, much more nuanced. And I'd love to have time to be able to discuss this. When we went to the talk on the incidences of cesarean section, I don't know if it's useful saying it's the incidence is so many percent in such and such a country and so many percent in such and such a country, because all the countries are particularly different. Now, there was this guy called Visser, and he said there's the politics of birth, where if you're having your birth in Holland, the cesarean section rate is such and such. If you go 1 kilometer over the border into Germany, it's double. So there are other factors that are at play over here that makes this this data enormously granular. And it's very difficult to compare Caesars one place to another one. And all the indications are difficult, particularly in the developing world. So it's something we have to be careful of. Firstly, is being dogmatic. And secondly, we should be able to, if we're going to have arguments, that they should be gentle and they should be civilized. So we can have different points of view without bamboozling the opposition. Would you say that's true, Priya?
Yes, I agree. So I think, for a while, the Caesar WHO came out with this ideal rate, and then we believe that we shouldn't really have an ideal rate. But last year, the European Society of Perinatal Medicine, Bo Jacobson and his colleagues looked at their European data, and they've come up with the 15 to 20% rate for Europe, and they found that was associated with the lowest, a rate of 15 or 20% was associated with the lowest perinatal mortality and maternal mortality. And that's the rate that, Europe should be aiming at. And after 20%, there was no additional benefit in terms of perinatal mortality. So that's where the rates have come up again, because for a while, the old suggestion by the WHO was sort of abandoned, and people felt that it shouldn't be considered. But this has come up again after the paper from the European Society.
Priya, can I just, okay, we're going off piece, but we have 1 more minute, I think. If I can just say that there's a huge difference between a healthy mother and a healthy baby and mortality. I don't want the lowest mortality. I want the rate that gives you the best outcome for the mother and the best outcome for the baby. You know, if you say to your patient, look, you're going to live, and the patient will say, I don't want to live, I want to be undamaged. And the same thing for the baby. The baby's going to live. I don't want a living baby. I want an undamaged baby. And that's where I took issue with Bo Jacobson at that talk, because I don't think you can talk about mortality. Why don't we talk about morbidity? I think that's a much better yardstick or measure than mortality. I think using mortality is a terrible, terrible denominator. That's my point of view.
I agree, especially in countries where the mortality rates are low. One should rather use morbidity.
I agree.
But it's very difficult to measure, the ideal rate, because it's difficult to measure future consequences. We're talking about pelvic organ damage, but we also risk of future pregnancies, whether the next labor is going to be managed in a safe way, the competence of the surgeon for the next pregnancy. So it's difficult to come up with ideal rates.
Yeah. You see, the other thing is this,
Yeah.
Priya. Laura Graves. She said something nice. So now, what was I going to say? Laura Graves took the wind out of my sails.
Well, Laura's
yes.
basically agreeing with you. I mean, she's a very popular and busy private obstetrician, and really agreeing with you. So I mean, there are many voices in this whole thing, Pete. But we do need to hear each other, and those of us who are at the coalface need to be heard too.
I'll just do one more comment.
One last comment. It is
one
6
last
o'clock.
comment. Seeing it on the chairman. It's about this. At that FIGO thing, Justice Hofmeyer was. I don't know if anybody knows Professor Justice, and he made a point years ago at a meeting over here that there was this problem of disrespectful maternal care in rural areas. And those of us that have worked in, well, not only rural areas, but worked in some areas, there's disrespectful maternal care where caregivers or midwives do tend to assault patients. And I brought this up as one of the reasons, and it's an absolutely bona fide true reason. If a woman in a rural area in this country and other countries as well delivers, they are subject to disrespectful care and they would rather have a Caesar. And I was approached later by a person from Sweden and says, I'm talking nonsense. She used a different word, a Swedish word. But actually, that's why I say that the data is granular. You can't necessarily compare what happens in Northern Europe and Europe to what happens in the developing country. That's why I say that our approach should be more nuanced when we're bringing up this subject. Steve, I think we are out of time. You better say goodbye to Priya before we start a different subject, different talk.
I think maybe if we do have an extra session before the end of the year, we can maybe just have a general discussion. And I think there's a lot to be said here. The voices from private practice, but also from state practice and from different corners of obstetric practice need to be heard. And I look forward to further discussion on this, but I do think we all need to go. Thank you very much, Priya.
Next time, Priya, next time, it's my very last sentence. We must have a guy like Better Obs and the chairman of Better Obs. It'd also be nice to have a talk like that. We haven't spoken about this on our platform yet, and it's a jolly good subject. So maybe Priya can make time. I know she's an extremely busy person, as you said, Steve. And thank you very much, Priya, for being with us this afternoon. And thank you for indulging us in some of these flights of fancy that some of us have gone off on. It's been wonderful to have you. And you, Steve. Thank you very much, Steve, for your time. And of course, Chris. So, Steve, the last word. Very last word.
Thanks to Pete as well. And we wish you well, Pete. I think you will be out of commission for 1 or 2 weeks coming up. So
I'm going for major surgery. So unfortunately, I won't be around for a couple of weeks. I'm going to be completely out of action, but maybe I'll bounce back faster than you could even anticipate, Steve.
All the best for that. And we thank everyone for joining, and we'll see you all next week. Thanks very much.
Thank you.
And thanks, Priya.
Bye.
Good
Bye.
luck, Priya, with your storms. All the best.
Thank you.
Bye-bye.
Thanks. Bye.